So I'm here to talk about diabetic ketoacidosis. It will be a topic that many of you are familiar with, and I'm not going to tell you how to do the basics that you do exceptionally well. Um, for those of you that are not from the UK, I would highly recommend the British Society for Paediatric Endocrinology and Diabetes BSPED guidelines. This has been finessed and changed many, many times over my career. And I think the current guidance is reasonable. I don't agree with absolutely everything in it, but it will work for most patients. So if you're not familiar with it, it is a really good resource. It takes you through step for step, and it will talk about the basics of fluid, insulin, electrolytes. I suppose the one thing I don't particularly like about it is that it's a little bit they're quite keen on fluid boluses, which I would still be a little bit more reserved about. I think 20 mils per kilo as a bolus is probably as much as you need to give for the majority of patients, even if they're really quite dehydrated. So they go up to 40 mils per kilo. And that is the standard guidance, but I personally wouldn't generally go that far. So what do people worry about in terms of DKA? Sorry about the door. The people worry about the pH. How the degree of acidosis. It they're really quite fixated on it. Sorry, apologies at work. They also worry very much about cerebral edema, and they worry about fluid management, more precisely the calculations of fluid. And the BSPED guidelines that I alluded to before are absolutely walk you through those. So they make it really, really easy. So that's what people worry about, but that is not what I worry about. So what do I worry about? I worry about misdiagnosis. We sometimes label things as DKA when they're not, or we miss DKA. So the classic things are in the mid of winter, when everybody's got bronchiolitis or chesty infections on this side of the equator. We occasionally miss the odd DKA, first of all, treating it as a chest infection, which seems a bit crazy, but it happens. Those of you that can smell ketones will pick it up straight away, but not everybody has that genetic ability. And if you haven't thought about DKA, you will miss it. The other classic things that are misdiagnosis are with children with DKA who get treated as an appendicitis because they have pain in their abdomen. They've got a little bit of acidosis, but actually they've got DKA, and vice versa. Somebody that's got abdominal badness going on and their sugars are high, their pH is high, their lactate is high, but they don't actually have ketones and they don't have DKA. So that's a group that, again gets missed. And if you don't question, is this a DKA or could this be DKA, and not everything with a high sugar is DKA, then you will miss that. The other thing I worry about is non-response to usual treatment, and we're going to talk about that in a bit more detail. I do also worry about GCS because I'm really not terribly keen to go anywhere near a DKA with a laryngoscope. Their GCS has to be pretty bad and they need to be in extremis before I'd even think about that. And I'll explain that through the course and the case as well. So everybody worries about edema. It's a thing, DK edema. So who's most at risk? So new onset type 1, age under 2, because parents and doctors don't pick it up as early because they're in nappies, they don't know they've got polyuria, they might not notice that they're polydipsic. So they turn up a little bit later, or someone that's got prolonged illness. But the truth is, it can be any single person with DKA. And if we did an MRI on all the children in DKA, over 50% and maybe up to 80% in some studies have a degree of edema. And it's been the real fear and the driving change of why algorithms and pathways have changed over the years. And we certainly give a lot less fluid these days than we did at the beginning of my career. And we limit in the UK 10% dehydration rather than go up to 15% dehydration, because we've proven over the years that we are really terrible at deciding who's dehydrated and how dehydrated they are. And particularly in DK, when they're breathing fast, they're going to have dry lips. They've got Kussmaul breathing. They're usually cold to the fingertips and their edge because they're acidotic. So it's really tricky. Weight in a known diabetic is the most accurate way of knowing how dehydrated someone is. But usually these children in the UK are new onset these days. In terms of cerebral edema, all patients with DKA are at risk, although there are specific groups. It's really important the days that we now swap between shifts and there's not continuity of care, that you hand over very carefully what the conscious level was. And as they arrive, if you're acidotic, you're going to be a little bit confused. That just goes, you're not supposed to function at a pH of 7. You're supposed to function properly at normal pH. So they were always a little bit confused. But a change in conscious level needs to be taken really seriously. And a new onset of headache in the teenage child who can tell you about it. But most of our children can't do that. So they're not going to tell you there's a headache. But it's really important that conscious level is documented and recurrently assessed, ideally by the same person. And it's much more likely to happen in the first 12 to 24 hours. So if you think that you've got cerebral edema, you need to treat it. So I know you've talked about neuroprotection earlier today in terms of TBI. Some of the basics here are the same. So sit the child up. The quickest thing to do is to half the fluids. The current protocol may say differently, and the one at the moment does, but this is the easiest thing to do straight away, and then you can look up what the current guidance is. And then I would give 3 mils per kilo of hypertonic saline, and then I would get the CT. And I would do it in that order, because if you really think this is cerebral edema, treat it, then get your CT. And as I said before, really step away from intubation unless you're in absolute extremis, and in the ideal world you've discussed this with PICU, because we really don't want to do that unless we could make things an awful lot worse. So why do we do a CT? Well, obviously looking for edema, but actually that's usually not what I'm looking for. I'm actually looking for another cause. Why has this person dropped their conscious level? Is it because they're really dehydrated and they've actually got a sinus thrombosis? Children with DK are at risk of thrombosis. That's why we tend not to put lots of big lines in and arterial lines in, even when they're sick enough to need intensive care, because they're at high risk of clot. Or have they actually bled? Is there something else going on? So the CT is there to look for edema, look for other events, such as sinus thrombosis and bleeding, which are less common. Most of the time these days when we do a CT, it's normal, but not always. So let's talk through a case. So this is a child who's 14-year-old, presented with vomiting, BM25, pH 6.8, the CO2 is less than 1.3. Bicarbonate is unrecordable, ketones are 5. GCS on admission is 13 and respirate is 35. Child is comfortably breathing, and I think we can all agree this child has good DKA unless there's something else in the history that we don't know about. They were shocked in presentation and given 20 mils per kilo of fluids. The GCS then subsequently fell to 9 to 10. While they were ringing intensive care, they had given 3 mil per kilo of hypertonic saline and a further bolus of 10 mil per kilo of fluid at the same time, which is a little bit unusual because on one hand you're trying to treat edema, which we've said is we give less fluid, and at the other side the team believed that this child was still shocked, so gave some more fluid. The GCS rose 13 to 14 and the CT subsequently was normal. They contacted PICU to talk to, they were in a district general hospital. Heart rate was rising, now up to 160. They were cool. The CAT refill was less than 3, blood pressure was stable, and the GCS was fluctuant. While on the phone, the GCS dropped again, and the team treating the child gave a further dose of hypertonic saline, but it didn't actually do anything. So the question here was, what are we treating? Is this a child who is obviously severe DKA, who has a low pH, which is enough to make them confused, As they came through the door, they had good signs of shock, which was treated, but they've also got concerns that this child has cerebral edema due to, and has risk factors for that first presentation, etc. Discussion with the team was this: is this child dry versus edema? We've got a CT scan that is normal, but as we've all been taught, the normal CT scan does not equate to the fact your ICP is normal. So yes, it was reassuring, but was it that reassuring? On further discussion, it really did sound like this child was really dry, but on discussion with PICU, we could not get the local team they were so terrified of edema, cerebral edema, which is the thing we're told about so frequently and the thing that we are told kills children, that they could not bring themselves to increase any further fluids. These were the initial gases at the time of the call. So, where pH is low, and the CO2, those of you that don't intubate regularly will probably not pay an awful lot of attention to CO2 in a DK, because you're looking at you're looking at the pH, you're looking at the base excess, you're looking at the sugar, you're looking at the electrolytes. The child is trying to compensate themselves, and they're blowing off CO2, and it is often exceptionally low. So a CO2 of 1.3, 2.8 is not uncommon in this group of patients. And this is partly why we're not keen to intubate them, because trying to replicate that on a ventilator to blow off enough CO2 is almost impossible. So intubating could actually make this situation much worse if, and this child is maintaining their airway. So there was no question of intubation at this point. And I would very strongly advise you to, if there is time to discuss, if you're planning to intubate someone with DK, that you talk to an expert about it, because you can do a lot more harm. Just to give you a little bit more background, these were the initial bloods that came back. So sodium's 140, you can see them. For the age of the child, perhaps the urea and creatinine are a little bit higher than you'd expect, and the phosphate is low, which is in keeping with the diagnosis of DKA. The child was collected and transferred to our unit. It took quite a long time. And as you can see, if you just look along, there was absolutely no response with the pH. And again, there was discussion with the transport team in relation to this, but not with the receiving unit. And clearly the current treatment wasn't working. We were absolutely stuck. pH had not moved over hours, and there had been no improvement with the current management. And as you say, draw your attention to the CO2. Look how low it stays. Bicarbonate, most of the time we didn't get a recordable one. Base excess is exceptionally high as well, and keeping with being dry. And the chloride is rising. The lactate was high on admission, but subsequently fell, and the sugar is being treated. Most importantly, on arrival, this child had deteriorated from a GCS point of view. So if you'll remember, we're sitting at sort of 12, 13 at the point of referral. This child's GCS was very definitely lower by the time they arrived in the unit, which was 6 to 8, which is really rather worrying. But she was maintaining her airway. So at this point, standard management is not working. They've treated this child as a cerebral edema, and just having done that, the child has deteriorated from a GCS point of view and has made no progress in terms of resolving acidosis or resolving DKA. So at this point, it would be useful to look at the anion gap. It's typical to have a raised anion gap of 20 to 30 millimoles per litre in DKA. If it's more than 35, it's one of the indications to go, have I actually got the diagnosis right? Is there sepsis? Is there something else going on? Is this right? So the anion gap continuing is maybe due to inadequate resuscitation, sepsis, might be because you've got insufficient insulin to switch off the ketones, or it could be because there's salicylates or some other drug involved that's giving you an unusual picture. So we look at these gases again, and we bring in the anion gap. Now, to start with, it was over that 35 number. It was 38. That's because we had no bicarbonate. But it became more in keeping with a standard DKA. So I think it was reassuring that we had DKA and that we weren't missing something else going on. But the treatment that had continued was not working. So then I go on to look at a corrected sodium, which I wouldn't do for every DKA, but when there is a child that standard treatment is not working, which is unusual and rare, then I look at corrected sodium. Corrected sodium is controversial. Not everyone believes in it, but I have found it really helpful over the years in the very complex, difficult DKAs. I found it a useful thing to do. So tells you how to work out your corrected sodium. If your corrected sodium rises by greater than 5 millimoles in 48 hours, you're probably losing too much fluid and you need to increase the amount of fluid you're giving. On the opposite hand, if it's falling over that time, you're gaining too much fluid, which is a risk for cerebral edema. Now, just to make a point, cerebral edema is not all just about fluid management. Certainly in the past, when we were very aggressive with excessive fluid, it didn't help. But a child that can come in and have, horrendous cerebral edema from before we even start treating them. So it's much more complex, and it's about changes in osmolality and all sorts of things, which are too complex for this chat. If the corrected sodium is falling or not rising is one of the things you need to think about looking for signs of cerebral edema. And I would just reference the paper if you want to read more about the use of corrected sodium. Durward et al. The paper is at the bottom and it's worth a read. And if you work in the UK, the Evelina protocol is interesting and quite a different approach to DKA management. It's not what I would use on a day-to-day basis, but it is a useful adjunct when things are not working out as you might expect. So if we look at if we add in our corrected sodium over the hours, this child had a rise of 7 to 12 millimoles over 5 hours. This all point, when the child arrived, they looked as dry as a stick. They were tachycardic. However, they dropped their GCS. The local team had been too scared to increase the fluids in terms of cerebral edema. To be quite honest, so had our transport team. And I understand why, because it's so drummed into everyone to be careful. But in actual fact, this child was exceptionally dry and we had not resuscitated them. We were not giving them enough fluid. So in terms of fluid management, what did we do? So the first thing we did was change to Plasma-Lyte because this child had been given normal saline. The chloride was rising and was contributing a little to the acidosis. It was not the main problem. So but we were hyperchloremic. At the onset of the concern about drop in GCS and concern about cerebral edema, they had worked out her deficit at 10% and had been given maintenance fluid, which had been reduced by half, and the deficit was being given over 72 hours, which is the current advice for cerebral edema according to BSPED. So what we did was basically go back to, I did consider, will we do something a little bit more complex and a little bit more mathematical and use the Evelina protocol to increase things a little bit. But to be honest, in the next couple of hours, all we did was return the deficit to being replaced over 48 hours, and we returned the maintenance to full maintenance. So we went back to standard protocol. And then as the night went on, this child improved, the pH got better, the CO2 began to rise, the electrolytes got better, the lactate went away, the base excess disappeared, And the most important bit was the GCS steadily climbed from 8 up until normal. And by the morning, this child had pretty much, well, normal for ICU gas with low ketones. So the learning from this case is when there's non-response, number one, keep talking to your experts. Do try and listen. It is so drummed into people that cerebral edema leads to death that people are terrified of actually considering that you might need to give fluid. And I understand that. And most times, this is an unusual situation. We're not usually so dry that we're so far behind here, but it is possible. If there's no response, your pH is not improving. And remember, when you start treatment, your pH almost always drops for the first couple of hours and then improves, particularly if it's at the lower end of the scale. So that's normal, but it should improve over the next number of hours. If it's not, review the diagnosis. Are you sure this is DK? Look at your anion gut, look at your potassium, take the history, make sure that actually you have everything you need to have to make DK work and that you're not missing a sepsis or an abdominal disaster. Remember, in DK, not everything is edema. And then look at the evidence. And in terms of that, I mean, look at your numbers, think about it, spend some time. And in the vast majority of cases, standard DK management almost always works. And in this child, had they received the fluid earlier in the piece, they would not have deteriorated and had a GCS of 6 on arrival many hours later. We actually made them worse by being scared, which happens, but we have to be brave sometimes. Thank you. I'll take any questions.